A very good evening to all our viewers. We are back with a new webinar on the latest advancements in cardiology and imaging. We have many speakers who are renowned in this field and have done excellent work and are going to share about this with you in the upcoming sessions. There have been several exciting developments in the imaging modalities in cardiology. And our first speaker for today is Dr. Milind Desai, who would be talking about advanced imaging in CAD. Welcome, Doctor. You can please start with the presentation.
Hello, everybody. I would like to thank the organizers for giving me the opportunity to present today. I'm Milind Desai from the Cleveland Clinic. I shall be talking about the role of cardiac CT in clinical practice. I have no relevant financial conflicts of interest. So, while coronary imaging is the primary focus of cardiac CT, there's a lot more to cardiac CT than just coronaries. And that is the focus that I'm going to have. We will talk about how we can incorporate cardiac CT into our daily lives beyond the coronaries. But of course, the most important aspect of CT imaging is coronaries, where we can do not only calcium scoring using non-contrast CT, but also contrast-enhanced CT angiography. The other focus of cardiac CT in clinical practice involves a huge focus nowadays is for planning of a structural intervention like transcatheter aortic valve replacement, mitral valve replacement, tricuspid valve, as well as for preoperative planning prior to cardiac surgery. Additionally, there's a role in other aspects of valvular disease. There are many electrophysiology applications, including planning for left atrial appendage occlusion, evaluation for non-coronary cardiac situations like cardiac masses, pericardial disease, adult congenital heart disease, etc. So let's just walk through what some of the indications are and how we can manage these patients, how we can incorporate CT into our daily practice. Of course, non-contrast coronary CT, chest CT has been used for a while now to evaluate for calcium score for the plaque burden by calculating the calcium score in the coronaries. Multiple papers over different continents, over different generations have been published, which have shown that measuring calcification, coronary artery calcification provides incremental prognostic value. It remains to be made sure as we are evaluating this that the distribution varies by age, gender, as well as ethnicity. So anytime you are using calcium scoring for prognostication, it is important to take these things into mind, keep this into mind. This is data from the MESA study out of the United States demonstrating that Caucasian men have a substantial calcification burden at a much younger age compared to a Chinese woman, for example. How to incorporate coronary artery calcification in practice? At least in the United States, we do this MESA risk calculator. This is a simple tool available online where you take into account a patient's age, the amount of Agatston calcium score, what their ethnicity is, do they have other risk factors like smoking, family history, total cholesterol, what their HDL cholesterol is, what their blood pressure, systolic blood pressure is, and whether or not they are on medications for lipid lowering or hypertension. This, what ends up doing is gives us a risk score which can divide patients into different percentiles of risk that can help in terms of primary prevention. So it is taking calcium score on itself is not a good idea. Incorporating that in the overall context of primary prevention is the right way of doing practicing medicine in this context. Coronary CT angiography. What is an ideal patient? These folks, ideally, they should not have previous CAD. Typically, they should be intermediate to low intermediate probability with a regular rhythm. You should be able to achieve low heart rate, typically age less than 70, because once you get older, there's a lot of calcification that ends up creating problems in terms of diagnosis. Obesity results in a lot of noise. Of course, you give iodinated contrast, so creatinine clearance needs to be normal or near normal, otherwise you can put the patient in kidney failure, and a no contrast allergy. This is an example of a person with no calcification, but a very severe, very proximal LAD lesion due to a non-calcified plaque. That was very nicely seen on CT angiography. So CT angiography in stable coronary artery disease, multiple studies have demonstrated incremental prognostic value. One of them is the CONFIRM registry, the Scott Hart registry. So there's multiple large-scale data that have shown that incorporating CT angiography into the diagnostic armamentarium provides incremental prognostic value. Now, what to do? CT angiography versus stress testing, functional stress testing, especially in patients with stable chest pain. This PROMISE study has a large scale, the PROMISE study sponsored by the NIH has shown, along with Scott Hart CAPP studies, they have shown that the initial strategy of using CT angiography results in a significantly lower rate of MI, but higher rates of catheterization and downstream revascularization. However, there was no difference in long-term mortality. So as a strategy, you can potentially use CTA versus stress testing in the rightly selected patients. There's a huge role of CT angiography in the emergency room. In United States, this is a $10 billion industry. The strengths of CT angiography are very high sensitivity and a high negative predictive value. And multiple studies, the ACIRN, the ROMICAT, and the CT-STAT trial, what they have shown is that the CT angiography group has a much higher rate of discharge from the emergency room, a shorter length of stay, and a higher rate of detection of coronary artery disease. This results in lower upfront cost, but if not managed well, it could result in higher rate of downstream testing. So if we know what we are doing and using CT to its strength, it provides substantial incremental value in patients that present to the emergency room. There's the new kid on the block, the fractional flow reserve assessment using CT angiography. What started off as a research tool is quickly gaining momentum and is soon to be accepted in most labs, hopefully in many, many labs, as an adjunct as a diagnostic and potentially prognostic adjunct to simple coronary angiography. So more to come in this space. CT angiography remains the gold standard for assessment of coronary anomalies. Not only it can identify where the anomaly arises, but what is the course and whether or not the surrounding objects are occluding are compressing the coronary. And in terms of post-revascularization following stent, in smaller stent sizes, CT angiography is not good, but if you know the size of the stent is at least 2.5, if not 3 millimeters inside, then it can provide a relatively high negative predictive value. On the other hand, CT angiography is excellent for diagnosis of bypass graft location as well as patency with a very high negative predictive value reaching 99%. Moving on from the coronary realm into structural intervention. As most of us know, CT has a huge role in planning for transcatheter aortic valve replacement, not only looking at precise measurements of the annulus, but also peripheral artery disease, because we need, in order to make sure that it is safe to pass catheters. It can also look at distance of the coronary artery from the annuli, as well as the degree of calcification throughout the aortic vasculature. So a huge role in structural intervention. Again, similar transcatheter mitral valve replacement is rapidly emerging, and CT not only can help annular measurements, but can also estimate the neo-LVOT and predict which patients would be at a high risk for developing obstruction, and it can help plan the procedure. It can also help plan location of chest access, for many of these valve replacement require a small incision in the chest. So again, a huge role in planning for transcatheter valvular procedures. Preoperative planning prior to cardiac reoperation, so standard sternotomy-based operations, especially reoperations, CT plays a huge role in location of the graft, not only from a patency perspective, but where the grafts are traversing. The last thing you want to do during an operation is injure a graft during sternal re-entry. So CT plays a huge role for that. Also, in addition to that, it can identify aortic calcification as well as if the other cardiac organs are attached to the chest wall, like the image on the right where the RV is tethered to the chest wall. In other valvular diseases, CT plays a major role. For prosthetic valve, especially mechanical valves, it can help detect whether the closing and opening of the mechanical valve is appropriate or not. Sometimes surface echocardiography and angiography are not sufficient, and CT plays an important role. The other interesting thing that we have recognized recently is the appearance of thrombus formation, especially in the TAVR population. And CT is excellent at identification of these thrombus, as the image is shown in the middle panel. Of course, with increasing incidence of endocarditis of prosthetic valves, CT plays a huge role in identification of aortic root abscesses as well as for pre-procedural planning. Other aspects of cardiology, cardiac masses, CT can serve as an adjunct to other imaging, where it can not only identify the tumor, but it can look at the other chest, whether or not the tumor is invasive, and as well as there are any metastatic lesions within the chest. The image on the left, this patient was thought to have an apical variant of hypertrophic cardiomyopathy, but when we did the CT, what we found was this person actually has an intramuscular lipoma. On the other side, the image on the right is somebody with a sarcoma, an invasive carcinoma, spindle cell carcinoma, where it is invading the left atrial wall. There are multiple lesions. This person generally has a poor prognosis. Another important role, adjunct role, is in assessment of pericardial disease. The images on the left show somebody with a congenital absence of the pericardium. The panel on the right demonstrates a patient with calcification to suggest constrictive pericarditis, and a cine image which suggests actual severe calcification resulting in constrictive pericarditis. So broad role in pericardial disease as an adjunct to echocardiography. Adult congenital heart disease, again, sky's the limit. Typically, we do echocardiography and cardiac MRI, but often these patients have a lot of devices and CT is necessary. This is certainly not a one-size-fits-all, and a tailored protocol needs to be devised in conjunction with a specialist in congenital heart disease. But having said that, in the rightly selected patient, CT plays a huge role. The image on the left shows somebody with a sinus venosus, ASD, and anomalous pulmonary venous return. And the image on the right shows a patient with a coarctation of aorta. But in adult congenital heart disease, essentially sky's the limit, and you can, as long as you tailor the appropriate protocol. Electrophysiology, again, a huge role now emerging with the left atrial appendage occluder devices like the Watchman device. CT can not only help with measurements of the annulus, of the left atrial appendage, but how many lobes there are, as well as it has a very high negative predictive value for evaluating of left atrial appendage thrombus. Of course, CT plays a huge role in terms of diagnosis of pulmonary vein stenosis. The panel on the right shows a patient who developed severe stenosis after pulmonary vein isolation. It is also important to pay attention to extravascular findings. Sometimes CT helps to refocus the attention. These are 3 cases that we saw in our practice. The top left, a patient coming for a cardiac evaluation with a large lung mass. The middle panel demonstrates a patient with esophageal cancer. And the third panel, bottom panel, shows evidence of severe pulmonary fibrosis. Again, this helps refocus the attention from cardiac disease into what is truly wrong with this patient. So to conclude, cardiac CT is very established now for coronary artery disease evaluation for the full spectrum, not only primary prevention using coronary artery calcium scoring, but for advanced, stable coronary artery disease, and there is enough data that it is just about as good as stress echocardiography in terms of long-term prognostic information. Having said that, it also plays a very important adjunctive role in all other facets of cardiovascular medicine, including valve disease, structural intervention planning, cardiac reoperation planning, electrophysiology, congenital, cardiac masses, pericardial, as well as aortic disease. But it remains important to recognize that it is not a one-size-fits-all imaging protocol. You have to tailor the imaging protocol according to a given indication. Thank you so much.
Thank you, Dr. Milind. That was a very insightful presentation. Moving on to our next session, I would like to introduce Dr. Milan Chag, who would be talking about CAD management, anatomy, physiology, and its imaging.
I'll discuss something about anatomy. Physiology was already discussed by Dr. Tejas Patel, and but there are two more lectures on FFR. So I think I'll discuss about something about imaging during coronary artery disease management, especially during intervention. So like this is a case, 35-year-old male, acute anterior MI, STEMI, 2 hours duration, no risk factors. He had stable hemodynamics, and he presented to a peripheral center. This is not playing, okay. So there is a large thrombotic occlusion in LAD, huge thrombus burden, and he was given tirofiban at that time, because when thrombus burden is too much, if you put stent also may get thrombus. So tirofiban is given, and after it was given for 24 hours in peripheral centers, and DAPT was of course was given, and he was taken up for check angiography 4 days later. And then if you see the thrombus has actually dissolved, there is still some residual narrowing. So he was advised angioplasty, but patient wanted to come here. Some of his relative was treated by me. So he came here after 1 week with a plan to do angiography. And I thought that I'll do under intracoronary imaging to assess why this young boy had an acute MI and now thrombus burden was very less. So actually after 11 days of tirofiban, he came to me and I did angiography, and this was angiogram. It was almost normal looking angiogram. So what happened actually? CAG was nearly normal, no thrombosis seen, barely recognizable, even plaque was not seen. So I decided to do OCT. OCT means optical coherence tomography. Next slide, I'll show you what it is. So here you pass a infrared camera inside the artery over a guide wire like a PTCA balloon. It actually sees the lumen. So entire luminogram is seen, and this is some enlarged thing, and this is a large lipid pool. This bright structure is a fibrous tissue, which are a very stable thing, while this is a lipid pool, which is a thin capped fibrous atheroma. And you can see that there is some intimal tear. And this tear actually led to thrombus formation, and there was a chunk of a thrombus, and which blocked the artery totally, led to acute STEMI. Luckily, reached to time in a center where everything was given properly. And now patient has no residual stenosis, and he can be managed medically by aggressive medical management. Of course, if you don't treat this kind of lipid pool by aggressive statin and dual antiplatelet therapy, this patient is at risk of a recurrent event. But as the residual lumen is good, at present, he can be still given a chance for medical management. So this is what is OCT. What are the principles? As I told that it uses a technology known as infrared light, which has wavelength of around 1300 nanometers, very high resolution, about 10 micron. It goes, it leads to intracoronary images, which is 10 times higher than intravascular ultrasound. You can get short axis view like this. You can get longitudinal view, and you can get 3D fly-through view, as if you are sitting inside the lumen. So this is the console on which we can see this. This is the catheter, which is 2.7 French Dragonfly duo imaging catheter. Is a fiber optic catheter. It goes like a PTC, a balloon or stent on the wire, and then what you can do is measure it. See PCI outcomes, and now there are so many randomized trials which has clearly shown that PCI outcomes are better with intravascular imaging, whether you use intravascular ultrasound or you use optical coherence tomography. It is better than angiography guided PCI. So it is time for high resolution imaging. Just for comparison, when you are using CT angiography, your resolution is 600 micron. If you do invasive angiography, your resolution is 200 micron. When you use IVUS, it is 100 micron, and when you use OCT, it is 10 micron. So it is very, very high resolution imaging at present available in the clinical practice. What is the algorithm? You can do pre-PCI assessment, what is known as MLD, and then you can do post-PCI, that is known as MAX. So you can assess the morphology of the lesion, why patient develop SCS or angina or whatever is there. What is the length of the lesion? What is the diameter of the lesion? If you do angiographic assessment, you are not accurate. If you do OCT guided, you can select the diameter of the stent, length of the stent, and you can decide what is the morphology, how much is calcium, lipid, fibrous tissue, and other things. Post PCI, sometimes edge dissection is there at the edge of stent, which is not sometimes visible by angiogram. You can see that your stent is fully apposed to the vessel wall. It is fully expanded, and I have added third dimension also, post PCI follow-up OCT. When patient comes either because of stent thrombosis early or late, there can be neointima because of neointimal hyperplasia because of stent property, or sometimes because of improper stent expansion. And even after several years, you can get neoatherosclerosis also, even if it is a drug-eluting stent. New atheroma, like any other normal coronary artery, new plaque can form. Neoatherosclerosis also can occur inside the stent even after 10 years. So it doesn't mean that once stent is done, patients, that segment is normal for the life. No, he has to control his secondary risk factors throughout the life. So when you do this coronary injury, you can see intima, media, and adventitia so clearly. You can measure the diameter of the vessel very clearly. So this is how fibrous plaque looks, very bright, orange structure. This is fibrous plaque. If it is a calcium, you can see the sharply defined margin. It is calcium. And lipid pool is actually dark and nothing is seen behind. Light cannot go beyond the lipid, so everything is dark behind this. So this is a dangerous thing. Lipid pool is always dangerous. You can see thin cap fibroatheroma followed by lipid here. So this is a vulnerable plaque. You can see plaque rupture. You can see red thrombus, which is fibrin rich. This is platelet rich. This is platelet rich white thrombus. Once you put stent, you can see that stent margin is fully apposed. If it is mal-apposed stent, you can see that stent struts are floating in the lumen. You have to go and re-expand the stent. You can see stent thrombosis inside the stent. There is again red thrombus, acute stent thrombosis. And this is a kind of dissection. Once you have got dissection either spontaneously or after stent like this, you have to re-stent. You have to just tackle this plaque to the lumen, otherwise it can re-thrombose. Thrombosis can occur in this area, whether it is because of stent age or spontaneous. So you can check the diameter of the lesion, you can measure the length of the lesion, you can check the calcium, whether it is a deep calcium like this, which can be tackled, lumen is good, you can do simple balloon angioplasty and stenting. If it is superficial, just this is a intima and calcium is here. This kind of calcium needs further treatment like intravascular lithotripsy or rotablation. This is a calcium nodule sitting like a stone. Cannot be, if you put stent here, stent will never expand. You have to treat by rotablation or rotatripsy, which we listen in the morning. So this is the treatment protocol. If in post-PCI status, you can see instant thrombosis. When post-PCI patient comes with angina or acute MI or acute coronary syndrome, you have to do OCT to assess what is the cause. Then and then you can correct the pathophysiology of the event. So you can have stent thrombosis, you can have covered stent, you can have uncovered stent. That also can be seen here. The stent studs are covered by intima. Here, uncovered stents are there, not covered by this thing. This stent is, if it is beyond 6 months, this patient is prone to stent thrombosis. If he stops DAPT, you can have instant new intimal hyperplasia. You can have fresh lipid pool inside, that is known as new atherosclerosis. There is calcium in the new atherosclerosis, also can be there like any native lesion, and there can be severe restenosis because of new intimal hyperplasia. So treatment is different. If there is stent thrombosis like this, that means your stent is possibly underexpanded. If there is new atheroma, you have to treat like any new lesion. If there is intimal hyperplasia, you will need another stent, and you have to correct all this hyperplasia by very aggressive balloon dilatations. One example, just before end, 3 vessel disease, inoperable patient because of post-renal transplant status. You have to do left main plasty here. If you want to do that, you have to give stent-like results. Did OCT guided PTCA. Reconfirm that everything is fine because you are treating left main bifurcation. And then you can see that when you put stent across left main to LAD, circumflex ostium should remain open. And this is what is demonstrated here nicely. And this is how stent looks like. So when it is now class 2A indication, intravascular imaging should be done. And if you are doing it, you are going as if you are going inside the lumen. You are seeing it like this. You are happy. Thank you.
Thank you, Dr. Milind. That was a very interesting session, which brings us to our last session of the day, which is on emerging role of telehealth in management of cardiovascular diseases. And this session will be taken by Dr. Ramesh Gowda.
And my last lecture for today is talk about the telehealth in the management of cardiovascular diseases. And I have no disclosures. What is telehealth? Telehealth is an umbrella term for a delivery of healthcare services information using electronic methods, sometimes used interchangeably with digital health, and also called telemedicine, allows for patient care without direct patient contact. It first started in rural America, where patients had less access to care. Encompasses telemedicine research, disaster responses, and relates to delivery of remote clinical services. So there are several methods to deliver these remote clinical services. It's a live or synchronous method where patient and physicians speak in real time through video conferencing tools. They store and forward the data between the provider and the patient, and you can review it at any point of time. It's saved in the digital format, and many technologies are available which can reassess between patients and the provider, and you can share among your colleagues. And mHealth, the mobile health, is use of mobile devices such as watches or smartphones to collect the same data. Previously, the patient had to be either in another physician's office or rural area to access to do telemedicine. However, since March 2020 coincides with the COVID pandemic, Centers of Medicare and Medicaid services in the US expanded coverage for all telehealth visits anywhere in the country. Beyond virtual consultations, there are about 120 telehealth companies and many more. The big ones are the Zoom, which is the platform we're using now for this teleconference, the Skype, Google Duo, Doximity Dialer, Doximi, FaceTime, WhatsApp, and to name a few. And both Zoom and Skype can be made HIPAA compliant. HIPAA means for the Patient Protection Act through the use of business associate agreement. Or you set up, you try to get a communication platform in place, the audio visual, and then add devices to the examination if possible, and make the visit more meaningful. And this is just an example of how a physician can talk to a patient and share data, including imaging, and in a live ECG and in monitoring, and still able to consult other physicians, other providers, and still get the effective care. In October 2020, Livermore received FDA clearance for the world's first prescriptible wearable for continuous heart monitoring. In a major trial of 270 patients, there was 100% sensitivity to identify atrial fibrillation, and 93% of patients where there was no atrial fibrillation, called the Livermore Halo trial. So when an Apple Watch, the Series 4 and 5, 6 can record an ECG, it's so useful. Like, for example, a patient having chest pain or unusual symptoms or irregular heartbeat or skip beat, they can tell him an ECG and transmit and save it and transfer to the physician. And actually, recently we heard about a physician who had chest pain, was able to get the ECG and was noted some ECG changes, called EMS, went to the hospital, was found to have 3 vessel disease, and underwent an emergency CABG. So it's a useful tool, but again, doesn't replace an existing established methods, but still it's an evolving technology. Telehealth in cardiology is the future is today, and it's important to continue to progress this. And what are the big 4 items? Applications, advantages, and our implementation and challenges. And applications include preventing late presentation of acute illness, so risk factor modification, medication refill and adherence, and lifestyle counseling. And it minimizes exposure of patients and staff and increases opportunity for patient-provider and in interaction, elevate patient-physician shortages, utilize of entire cardiovascular care team, including nurse practitioner, physician extenders, and implementation, appropriate patient selection is important. Patients who are familiar with electronic gadgets, and make sure they have smartphones or iPad or computers, and make sure they have the right platform. Like in our hospital system, use called Epic EMR, which has the IQ app, and it's very user friendly to do a MyChart communication, clinical workflow, and obviously licensure and liability has to be discussed with the IT. And talk about the billing and the documentation now exactly about for telehealth. Now, what are the challenges? Patients have to agree to participate in this. There are barriers with access and limitations, and patient privacy is a concern. Technological gap, reimbursement, is it paid enough, especially by insurance companies, and the initial clinical inertia and the liability. However, in the future, we need to know whether this telehealth impacts clinical outcomes. And coming to telemedicine, heart failure is a very prevalent condition, as we know, and it's important to monitor these patients both in the hospital and outpatient clinic. 2 important goals is to individualize care and reduce costs by reducing recurrent hospital admissions. And the 2 types of monitoring which have been tried, the invasive hemodynamic or the cardiomems, which device implanted in the pulmonary artery, on COMPASS heart failure trial, but there's a transvenous lead placed in the right ventricle. There are other non-invasive methods with respect to weight changes and telephone support, and hand smartphone apps can be used to monitor heart failure patients. And trials regarding invasive and non-invasive telemetry and telephone support show divergent results, with CardioMEMS device showing significant reduction in hospitalization. There's few meta-analyses showing there is some reduction in mortality and morbidity and improvement in quality of life. This is a picture demonstrating CardioMEMS device. It's a very small handheld device, similar to a small coin, and it is delivered through a catheter into a pulmonary artery, and basically patient monitors at home. We're coming to vascular specialists. That's one of my favorites field of practice. And there's an app called CarePix, which is easy to use mobile app and web application, which coordinate patients, vascular specialists, and wound care patients and centers between the nursing department, the podiatrists, and the vascular specialists, and coordinates regarding their visits and medical supplies. And what do the patients do? Patients can reduce their travel, save time, money, limit exposure to contagious diseases. For podiatrists, track the wound healing progress in critical ischemia, peripheral arterial disease, chronic wound patients, while streamlining specialty consult workflows. Vascular specialists can triage high-risk patients ahead of time and plan for interventional procedures, and also monitor post-procedure follow-up. Primary care physicians have virtual communication with remote wound care services and help ensure patient compliance. Wound care clinics consolidate this complex patient coordination between clinic and specialty physicians and track their wound healing progress. And skilled nursing facilities can identify these patients and send to facilities where they can get this advanced equipment with respect to oxygen, wheelchair, crutches, blood test strips. All this can be fulfilled. And home health methods have no-cost solution for wound care and healing documentation, along with easy-to-create patient reports. So this one such example called the Siren Socks. It helps detect injuries by monitoring the temperature of 6 regions of the foot. If one region is warmer than the others, it indicates inflammation caused by injury. It could be very useful in diabetics The socks then connects to your patient's phone via Bluetooth, and then the doctors can see what are the red flags. And in the University of Michigan did study recently during the COVID era about aging population and what is the telemedicine in older adults. There's a growing interest, but there are some concerns. So in this survey, 75% of adults, healthcare providers not able to conduct physical exam is a concern. 67% said quality of care is not as good in televisits compared to in-person visits. And 45% not feeling personally connected to the healthcare provider. They would like to have in person. They want to have a doctor touch their hand, touch their body, examine them. 25% having difficulties sensing or seeing or hearing healthcare providers. Again, telecommunication issues during telemedicine. And 25% are privacy concerns. And with respect to the market, what's happening, and there's a significant increase in telemedicine market, is a boon for patients, especially for people who like to have a fast-paced life. And there is a significant growth based on this persistent market research in telemedicine. And you could see the telecardiology is really picking up along with telepathology and then other fields. And health market also showing a significant increase in the global market, and the projection is by 2025 there's going to be almost 300 billion increase, and especially markets like India and China showing over 40% increase in the compound annual growth rate. What are the pros and cons of telehealth? Pros are more convenient and accessible patient care. It includes family and significant others at the ease of their homes, increased patient engagement, better patient quality, reduce healthcare cost, and extend specialty and referral physician services. Cons include technical training and equipment is required, reduced continuity of care on occasion, fewer in-person consults and lack of examination, tricky policies and privacy. Obviously, the reimbursement rules could be affected. However, the e-visits are the next frontier and a booming healthcare trend, and that will continue to progress. So what are the current myths about telehealth? The telehealth, telemedicine, e-health, you can use any other terminology interchangeably, is challenging. It lessens the doctor-patient relationship is a myth. It costs too much and doesn't pay is a myth. And it's not HIPAA compliant is a myth, and increases malpractice risk. These are all the myths, and it could be easily circumvented. To conclude, telehealth is here to stay. Remote monitoring will continue to grow as population ages and chronic conditions continue to rise. Regulators, payers, and patients providers have realized the advantage of remote evaluation of patients. It keeps evolving as the companies continue to develop new technologies to accurate physiological assessment of patients, especially at their homes. And telehealth has provided clinicians a recourse to continue delivering high-quality medical care, especially during this pandemic. Clinicians, healthcare systems, and public policymakers should continue to build upon this momentum and continue to make this as an important technology. I thank you for your attention.
On behalf of the entire team of Docplexus, I would like to express my gratitude to all our eminent speakers. Thank you for such an interesting and insightful session. We are looking forward to more such sessions from you, Doctor. And to all our viewers out there, thank you again for taking out your time and attending these sessions. We will be upcoming with more sessions in the future. So please stay safe, stay connected, and happy Docplexing.